All right, welcome, folks. Today we think we have a very important topic, and this is as we were looking through and trying to set up topics for this year, this one came to our attention as something we probably should address. Things are changing. It's a big onus out there that we have to shadows of hanging over us all the time. So we asked somebody who would we get to speak, and we had a unanimous confirmation that the person we're having today, Anna Fretwell, this is the people that had heard her before, said she knows her business and she delivers her message well. And so we were able to get Anna to come and join us today. She brings with her 20 years of experience, and this is experience on our side, that is, that defending physicians, defending nurses, defending PAs, all walks of medical care, as she's been there. And she also has been before the Georgia appellate courts with litigation. She was just telling us that they have multiple firms, as a lot of law firms do, they in various cities, and they have a small unit. They consider themselves small, and yet they have 50 attorneys, and so kind of tells us what to do. Anna started out her career at University of North Carolina, and there she graduated summa cum laude, and then decided to go to law school. Attended law school at the University of Georgia, and there was in was graduated again summa cum laude, and so her career is one of good background academics and a lot of experience, and so we look forward to hearing her presentation. It's kind of striking, risk reduction in electronic everything. Thank you, Anna.
Thank you so much, Morris. These lights are very bright. Good afternoon, everybody. Nice to be with you today. As Dr. Morris said, I have been doing medical malpractice defense work for 20 years, and I am here to hopefully reduce the risk that you ever see me again, or someone like me. So, oh, thank you. Better? All right. So, get the formalities out of the way. I don't have any financial relationships to disclose, and I know we're supposed to have some learning objectives, so let's go over those very quickly. Essentially, what we are here to do is, first of all, try to talk to you about ways to reduce the odds that patients go to a lawyer. And the best way to reduce the chance that a patient goes to a lawyer is to communicate effectively with the patient. So that's the first objective today. The second one is, if a patient does go to a lawyer, to increase the chance that that lawyer, when they evaluate the case, decide that it is not one worth pursuing. And the way to do that is with good documentation habits. So we'll talk about that today. And then the last thing is that once a case does get filed, and we certainly can't eliminate the risk of that happening, ways that you can act on the front end to make it easier for me or someone like me to defend what you did, to be able to establish and prove that you provided good care to the patient. So that's what we're after today. Lots of studies have been done about why it is that patients decide to pursue litigation, or why it is they decide to go talk to a personal injury lawyer about care that they have received. And those studies consistently show that issues with communicating with their healthcare team are really the number one thing that send patients to lawyers. So either they are frustrated because the physician was indifferent or wasn't responsive to them, was arrogant, didn't explain things in a way that they understood, left them confused, made them feel like they didn't have a choice about how to proceed, so that they were not really involved in the decision-making process for their healthcare. And all of those things lead to patients being frustrated with not only the outcome, but the process. And then often what patients do at that point is to decide, well, I need to go talk to a lawyer. I've had many cases where when I take a plaintiff's deposition, when I'm asking them after a lawsuit has been filed about what their reasoning was for going to a lawyer, and they say, because I couldn't get any answers from anybody. I didn't understand what had happened. And I felt like that this was the only way to understand what had happened. So yes, people are motivated by money. Yes, people are motivated because they feel like they need long-term care, but often it is really just feeling like they've been respected and getting answers. So to try to increase the possibility that you are communicating well with patients, there's a lot of, first of all, it's really helpful if you can communicate with family members too. If you go into a patient's room and you're talking about something fairly significant, a new diagnosis, treatment recommendations, options that a patient may want to consider, if a family member's not present, ask if there's somebody who's there. Maybe their family member has gone to lunch. Maybe their family member's in the waiting room because they felt like they didn't want to intrude. But it really is helpful to have a second person there or a third person there if the patient is comfortable with it to listen. Why is that helpful? Well, it's really helpful because if later there is a misunderstanding, sometimes that person can help the patient remember correctly. Or if the two people who were there don't have the same recollection, that will prompt someone to call back for clarification, as opposed to if just the patient misunderstands, they're just going to assume that they are right, and you might not have another chance to explain things. So having a second person there is great if possible. You want to try to communicate not just the end result of what you're recommending or what the diagnosis is or what the prognosis is, but also what your thought process is, to the extent you can make time for that. Obviously, I know you all know about informed consent, but informed consent really applies, it's a process. It's not just for a surgical procedure. It means if you're talking about other treatment options, medication versus surgery, medication now versus cardiac catheterization, you want to talk about the pros and cons of different choices and make sure patients understand ultimately it is their decision and you're there only to make recommendations. Often patients feel like they don't have enough time to make a decision because it hasn't been either, it's hard to get an appointment, so they feel like I have to make a decision today while I'm here because I might not be able to get back in touch with my healthcare provider for another 2 months, or they just don't understand that the condition that they have isn't something that has to be addressed as an emergency. Even if it's something that sounds scary, as all of you know, even cancer, which patients want removed yesterday, has been there for years. They have a week to go get a second opinion if they want to. It's important to communicate that they have time to make a good decision so that ultimately, if there is a bad outcome, they don't feel like I didn't have an opportunity to consider alternatives. So those are all things to keep in mind when you're communicating. Even if there is a bad outcome, and even if your communication is imperfect, even if the patient is confused, still doing the work of having the relationship with the patient where they feel like they can talk to you, where they don't feel dismissed, improves the chances that things can still get back on track and that they don't just run to a lawyer when something goes wrong. It improves the chance that you are going to be the one that they come ask questions to. It decreases the odds that they just go to Dr. Google, and then when they get there, they find either incorrect information, much more alarming information that doesn't put any context into likelihood, incidence rates, those kinds of things that really can only come from a professional. And perhaps most importantly, if you Google many health conditions, what you get is pages for lawyers who are looking for patients who have that condition. So if you Google birth injury, on the first page, you are going to get lawyers' websites. If you Google vaginal prolapse, on the first page, you're going to get lawyer websites. If you Google spinal cord injury, on the first page, you're going to get lawyer websites. So, and some of them aren't even obviously lawyer websites. They're sort of built to look like educational material, but once you click on them and you get in there, it's, you know, numbers to call to consult with a lawyer to see if you might have a claim. So it's a very short step for a patient to get from I'm irritated and don't really understand what's going on with my health to being on the phone with a lawyer or in a lawyer's office to talk about a potential claim. So anything that you can do to keep the interaction with you and not going outside will reduce the risk that that happens. I know this is too small for you to see, but hopefully you can get enough of the concept of it that you can grasp it. You know, medicine is complicated. It's complicated for people who don't have any medical background. Sometimes it's complicated for people like me who I do now, after 20 years, have a pretty good bit of practical medical knowledge. Pictures are really helpful. Pictures are helpful in the way they educate patients. They're helpful for patients to take home and be able to reconsider later. They are helpful to foster engagement between you and the patient in a way that just talking at the patient doesn't accomplish. So it can really just improve the openness of the relationship, the back and forth. It encourages patients to ask questions. This is an example that I've seen before from a physician who does gastric bypass surgery or other weight loss surgeries. He uses this picture to explain 3 different technical approaches to weight loss surgery. Each one of them lists the potential risks and the percentage likelihood of those things happening with that procedure. At the bottom, there's a list of average weight loss for each one, kind of pros and cons to each procedure. So what the physician does is he uses this to talk about the options. He makes a recommendation to the patient about which one he's recommending for that patient and why. You know, here's the stars explaining this is the one that I think is best for you. And then explains, you know, this is the main reason, or this is the main focus, though, of this one. It requires significant lifestyle changes. So talking to the patient ahead of time about what lifestyle changes are going to be required. You know, it's very hard if a patient leaves the office with this for them to say, well, I didn't understand that I was going to have to, you know, change the way I ate, because, you know, it's very well illustrated here. And then the physician initials, and then has a spot for the patient also to initial to show that they've gone over it. You know, so obviously something like this won't work in every specialty with regard to every procedure, but it's something to think about. Another good source these days is YouTube. You know, I don't recommend that you just get on YouTube for the first time when you're sitting with a patient to say, well, let's see what we can find, because you might find stuff you don't want them to see or that's not relevant to them, and that might be a waste of time. But if there's a condition or a procedure that you find yourself regularly talking to patients about, go online and see what's there that's helpful, that may be a good illustration that's applicable to them. Download it, you know, maintain it on an iPad or some other device that it's easy for you to show to patients, and present it to them. Show patients their x-rays or CT scans, the portions that are relevant. And all of that, you know, there's a lot of angst about what electronics has done to the practice of medicine, but there's a lot of upside too. And being able to use those tools to teach patients and show things to them is really helpful. This is a minor, trivial illustration, but I had to take my dog to the vet yesterday because he's been limping, and, you know, he had already been treated for some minor stuff. And of course, where does your mind go? It goes to maybe he has bone cancer, or, you know, maybe he has some awful whatever. And the vet took an x-ray and she brought it into the room on an iPad, blew it up for me to show me that his legs are just fine. And then I asked her, I said, well, how would you know if it was cancer? And she immediately went to Google Images and pulled up a x-ray of cancer in a dog's leg and says, this is what it would look like. Now, it's not that I didn't trust her when she just said it's not cancer, but it sure is a lot more reassuring to go home myself, having seen the pictures of what his leg looks like and what cancer would look like, and know, it's not just she didn't miss anything, it's just not there. So to the extent you can do that, really helps foster a good relationship with your patients and one of trust, so that if something does go wrong, their first thought is not, I'm going to sue them, or I need to go somewhere else to get answers. In today's diversified practice of medicine, there's a lot of use of intermediaries to communicate. I know every patient has multiple layers of people they end up interacting with. Every healthcare team is made up of multiple people: nurses, mid-levels, physicians, specialists, sometimes different types of nurses, phone triage nurses. And that's effective and useful as long as it's used appropriately. It is concerning when a team gets in the habit of physicians relying heavily on mid-levels relying heavily on nurses to communicate things that are really outside that person's purview or outside their specialty. I know that nurses and mid-levels have lots of training, and they get a lot of very specific experience in whatever area they're working in with a particular team. And often nurses effectively anticipate what a physician's going to say, what a diagnosis is, what the treatment recommendation is going to be. But if nurses are put in the position of communicating that information, and then patients have questions that either the nurse can't answer or the nurse really shouldn't be the one answering, then that creates exposure for everybody. It puts the nurse in the position of potentially exercising judgment that that nurse should not have to exercise and should not be exercising. Or if the nurse doesn't do that, if he decides, well, this is really outside my area of expertise, and the physician's not available, then it can put the patient in the position of having potentially alarming information and no ability to have any reassurance, because it's going to be another day before they can talk to the doctor about it. So be careful about what information is communicated. I mean, in general, I would say initial diagnoses should not be communicated by a nurse. You shouldn't have a nurse communicate the what the medical significance of findings are. Treatment plans should not be communicated initially by a nurse. Those things need to be deferred to a physician. Of course, follow-up questions may be appropriately directed to a nurse. Logistics may be appropriately directed to a nurse. Potential intervening events, like, here's the treatment plan, but if XYZ happens, then those things a nurse could certainly handle. So it's my little spiel on using intermediaries. And I talked about that, some of the pitfalls of that. Okay, so let's say that you have done all of those things really well, but nonetheless, patient has a bad outcome and decides to go talk to a lawyer for whatever reason. So there's a significant amount that happens between when a lawyer gets a potential client in the door and when a lawsuit is filed. And during that period of time, we on the care provider side really are not involved in the process at all. Sometimes we don't even know it's happening. Sometimes we get a medical records request, and so we do know that somebody may be looking at the case for whatever reason, but sometimes the medical records request comes from the patient herself, and in that situation, you may not know what the patient's planning to do with those records. So patient goes to a lawyer, the lawyer says, why are you here? And the patient says, well, I was treated at Emory and this bad thing happened to me, and I want to talk to you about whether I have a claim, whether I can file suit. And so the lawyer is first going to chat with the patient about the situation, get some sort of an idea about what it's about, and then they will request the records or have the patient request the records. Once they get a set of the records, they will send those records to a quote unquote expert. So someone who is a medical provider or some sort of a healthcare professional who's in the field at issue, or somehow close to the field at issue. And they will have that person review the records. They might have that person review a statement prepared by the patient explaining from the patient's standpoint what happened. And then that person will render an opinion. And if that opinion is critical of the care that was provided, the lawyer will ask that person to sign an affidavit stating what their opinions are. And then the lawyer files the lawsuit and includes the affidavit with the lawsuit. And often that is the first time that we know that there's an issue at all. With some exceptions, the statute of limitations in Georgia is 2 years from the date of injury. Often lawyers wait that entire 2 years to file suit. So sometimes it is 2 years later before we even know that anyone is complaining about the care. So when you are providing care to patients, you need to know in the process that I just described, what information is it that this lawyer is actually going to be evaluating? And usually what the lawyer is going to be evaluating is A, whatever the patient tells him or her, and B, the certified medical record, which is what they get when they make a request. The certified medical record may not be as comprehensive as you believe it to be. So it is what is in Power Chart that comes to them in a form that's quite different from what you're used to seeing, but nonetheless, what is in Power Chart comes to them. Any handwritten pages that happen to have been scanned into Power Chart, and that sort of varies by department and changes over time, but whatever gets scanned in is going to be sent to the lawyers or whoever requests the record. All of these things over here on the right are not part of the medical record. So imaging studies, the reports go, but the pictures do not, unless specifically and separately requested, which is rare. Internal routing forms or requisition forms are not included and usually are frankly are shredded. So those probably will never exist again. So if you just if you jot a diagnosis on a requisition form for a CT scan, and that's the only place the diagnosis is written, then that document will probably never exist. If you jot down, quick findings on some sort of routing sheet internally, that's probably not going to exist by the time litigation rolls around. If you just texted someone what your thoughts were about a patient and did not put a progress note in the chart, or you sent a quick email to someone about what you were thinking about the patient or asking them to consult on the patient and did not put any sort of a formal consult in or any note in the chart that you had made that phone call, depending on your cell phone provider and how long it is after that the suit gets filed and what has happened to your phone in the interim, and if you have gotten rid of it, text messages are only kept by most cell phone companies for about 3 months, sometimes up to a year, but a lot of this stuff is not retrievable. More importantly, though, it would never be seen by the lawyer who's first evaluating the case. The lawyer is going to have Power Chart, and that's it. So information that is relevant to the care of the patient, to your decision-making process, to what's been communicated to the patient and among members of the treatment team, that information needs to be in Power Chart, because you want the lawyer to know that you made that consult. You want the lawyer to know that you considered that diagnosis. That information needs to be in the record so that when the lawyer and the expert are looking at it, they can see, oh, well, they did think about that and they had some good reasons for not deciding to do it that way. So I'm not going to criticize that care. All right. So I know everybody here switched to EMR, which is great, except when it's not. So here's a few things just to keep in mind in terms of pitfalls associated with EMR. Templates are useful, but also can create headaches on the back end. So this is a nursing note in a hospital record in which the nurse is assessing a patient's lower extremity, and the patient is complaining of right knee pain and also screaming out in pain, yet also appearing comfortable, also appearing in no acute distress, and appearing uncomfortable, all in the same note. So when a lawyer gets this, there's no information to be derived from this note other than that we do not have a reliable assessment of what the patient's pain was at the time of this nurse's documentation. They might as well have not written anything at all. So when you are dealing with templates and autofill information, please make sure that your notes are internally consistent and delete old information, and do something that makes it clear that what you're putting in that note is a current assessment for now. Here's another example, the carry forward. So this is a patient who, I'm just going to skip forward one. So patient who is being seen by wound care at a hospital, follow-up visit for the patient transferred to rehab, patient seen from an outside hospital, patient seen with the doctor and the parents at the bedside by the wound care nurse. The dressing has been removed, the previous area of compartment syndrome, no E, with fasciotomy site open to outer calf, large central region of exposed muscle tendon, area concerning for viability as is yellow, brown, gray in color, chemical-like odor noted with dressing changes, right? And then that's on the 5th. On the 8th, same thing. Dr. Johnson and the parents are still at the bedside. Previous area of compartment syndrome, still there. Chemical-like odor noted with dressing removal, but not appreciated after wound cleanse. Same thing again. We still have the yellow, brown, gray in color. So nothing appears to be changing here. Now, it seems suspicious to me and other lawyers that this is really what's happening at every single visit. Are the parents and the physician really at the bedside every single time the wound nurse is there? I mean, I guess it's possible, but knowing what most lawyers who do this type of work know about how hospitals function, that's pretty unlikely. And the fact is that although the wound is, the same treatment is being provided and the wound doesn't seem to be getting any better, it just is described the same way every single time. So, it's always the same color for over a week. It's always the same odor. It always says that there's people there with the patient until this day on the 15th. So I'm not saying that you shouldn't use carry forward at all. I understand that retyping, that often patients' conditions are fairly static, and retyping the same information over and over is a pointless waste of time. But you do need to make sure that it's clear from your note that it is a new note. Even if you just add at the beginning of this, as was the case on November 8th, comma, and then describe, you can use the same information or the portions of the same information that are applicable. You can make a few changes and make it very clear that this is updated information and that you've been attentive to the patient. So, also just to let you know, and I've done this presentation 6 or 7 times, and every time when I get to this slide, I say, it's gonna put an example in the PowerPoint, and I never remembered to do it. When the software translates to a PDF, has anybody seen how these records print out? A few people have, not very many. So it doesn't look anything like what it looks like on your screen. On your screen, the information is usefully organized, and you can click on tabs and get chronologic trends of labs and vital signs, and you can easily go back through, date by date, each of the progress notes. I know how it looks on the screen. all of that information gets printed in a PDF that for a week-long hospitalization is about that fat. And it is not in necessarily any appreciable order, although generally stuff is grouped by like labs and progress notes and orders. It is very difficult to tell, like it'll say that the order was discontinued, but it's being printed after the hospitalization. So it's really hard to tell, when was that order discontinued? Was it discontinued because the patient was discharged and there was just sort of an automatic discontinuation of all the orders, or did somebody decide that patient didn't need that medication anymore? The drop-down menus that you can choose options from don't print at all. So if you don't choose any option from a drop-down menu, then that field is just not in the PDF. So no one looking at this PDF record would know that that field was even a choice. Also, the alternatives that you would be choosing from, if you pick, if it's mild, moderate, severe, if you pick moderate, it doesn't show that you were choosing from a drop-down menu. It looks like you just typed the word moderate. So there's a lot of stuff that's lost in translation in getting to that PDF, and they're hard to read. So just the main takeaway from that for the purposes of this talk is the easiest place for for lawyers to look in medical records to figure out what's going on is the H&P, the progress notes, and the discharge summary. The extent to, and we're good as lawyers at reading narratives, we're really not very good at interpreting data, or we just don't have the patience to study it very well. To the extent you're able to put even just a sentence or two in a daily progress note that's more than just a carry forward from the day before, that's a brief synthesis of what you're thinking, that's really, really useful. When a non-physician is trying to look at it later and figure out what was the thought process for this patient. So, okay, audit trails. Is there anyone here who has seen an audit trail for a medical record? Like 3 people. Okay. So audit trails are the metadata, or the information behind the medical record that demonstrates the timing and substance of all access to and changes to the medical record. It's all of the information that shows step by step exactly how the medical record was created over what period of time to get to look the way it does on the screen on any given day. So it is a dynamic thing. If you pull an audit trail for a medical record for a patient today and then pull the audit trail on that patient tomorrow, if they're still in the hospital, you'll get a whole different set of data. Lawyers have become very savvy about the significance of audit trails. They understand how to interpret them, and they understand that audit trails can demonstrate that records have been changed when it's not obvious from the chart itself. They can demonstrate who accessed a record and when. They can tell from where they accessed the chart, exactly what portions of the chart the individual clicked on, so what they reviewed, how long they were in the chart. Please do not think that you will ever get away with making a change to a medical record that someone will not know about later. That information is required by law to be preserved. It's part of the whole HIPAA high-tech legislation. And these audit trails routinely get requested once a lawsuit already has been filed. So if you're going to make a late note, call it a late note. Don't delete things from the record. And understand that if you decide to look at a patient's chart from home at 11 o'clock at night, and there's something alarming in the chart at that time, and you decide it can wait till the next day, and then something happens with that patient overnight, and there is a lawsuit, someone is going to know that you were aware of that information at 11 o'clock the night before. They will also know that you were looking at it from home instead of at the hospital. So here's a couple of examples to show you. So this is, I know you probably can't see this very well, but this is an office note from a pediatric practice. And it's a patient who came in on April 20th, 2016, a teenager who came in complaining of coughing and dizzy spells and hot flashes. The physician did an exam, and the assessment, which is one of the CPD codes, is dizziness and giddiness. This is on April 20th. That's the date of the visit. Oh, I'm not talking to the microphone. Sorry. Okay. Is that better? Okay. So that's the date of the visit, the 20th of April. I will tell you that this patient died on the 25th of April. Had a sudden event at home, collapsed, was taken to the hospital, couldn't be resuscitated. So here's the diagnosis of dizziness and giddiness that you saw on the record on the 20th. That diagnosis was entered on the 25th, which is the day the patient died. On the day the patient was in the office, which is on the 20th, the diagnosis was syncope and collapse. Okay. This patient was sent for, and I'll tell you, the care here was not bad. This patient was evaluated in the office, had total normal respiratory assessment, was sent for an EKG that day. The EKG was interpreted as normal, no return phone calls about any ongoing symptoms. Patient was really not complaining in the office and was sort of, aw shucks about the whole thing. My mom made me come in. I'm really not having any significant symptoms. So it isn't, this was, dizziness and giddiness was probably not an unreasonable diagnosis with a focus on dizziness. But originally the diagnosis was syncope and collapse. Now I'll tell you this, I mean, this physician's explanation for this is, well, syncope was really the diagnosis. Syncope and collapse is the way it comes up in the codes. I can't give, in this section of the EMR, I can't give him a diagnosis of just syncope. And then, yeah, looking back at it, syncope and collapse seemed excessively concerning. And so I thought this was a more appropriate diagnosis, which all may be very well and good, but it sure doesn't look good that he changed the diagnosis on the day the patient died of collapsing at home, you know? So this is very difficult to defend once it gets into litigation. And the lawyers know about this record, you know, we've had to produce it. So the right thing to do here would be one of two things. The one thing you could do is, oops, getting ahead of myself. One thing you could do here is you could say syncope and collapse because you had to pick that in the code, but then make sure that your narrative said, this is my diagnosis is syncope. I do not think the patient is any, you know, has any aspect of being anywhere near collapse or passing out or whatever, and make the explanation in the narrative. If you didn't do that and you were stuck with this diagnosis after the fact, then the thing to do would be to create a late note on the 25th that explained what your thinking was on the 20th. So either one of those would be preferable to changing the note in a way that makes it look like you were trying to cover it up. Here's another example of an audit trail. So this is a record of a hospital chart being accessed from home. It has the date. It has the time that each portion of the record was opened. It has the location from which it was opened. It has the physician's name who was doing the reviewing. It shows what they did to the record. So this was all just viewing the record, but if it was being added to or supplemented, it would say that it was edited. And then it shows which document in the record the physician was looking at. This is another, so you'll see the times on here are all between 22:31 and 23:08. So over a period of about 35 minutes, one evening, this physician was looking in the chart, and this is the case I alluded to earlier. You know, this physician, this is a surgeon who was on call. He was on call overnight, so he first came on call at 7 p.m., was told in report about this patient, was given a report that was rather benign. And then the initial story I got from this individual was, well, I was told that, you know, the patient was stable. There wasn't really any worry about the patient. They thought he had chronic cholecystitis, and We were just monitoring him, and so I didn't think I needed to see him until the next day. So the next morning when I got there, it was all terrible and much worse than I was expecting, and I had no way to know. Except that the night before, for 35 minutes, you looked at the labs and you looked at the progress notes and you looked at the imaging, which rather clearly showed a picture of sepsis and something acute going on in the abdomen. So you can't testify that you didn't have any idea what was going on until you got to the hospital the next day, because the audit trail proves that that's wrong. So you just need to be cognizant that this information is out there. Okay. There are other electronic world issues that you also need to be aware of. Email sometimes is recoverable, even if it's been deleted. Cell phone and text messages, as I said, you know, the cell phone companies don't usually keep text messages somewhere between 3 months and a year, typically, that they can actually provide us with what the substance of the text is. Although for longer periods of time, they can usually show us when texting was occurring and to what numbers. So they may be able to show that I texted my husband at 8:30, but it may not show what the actual substance of the message is. However, lots of people don't delete their phones very often. And so there are many times when we have cases where even after 2 years, when it's filed, we ask our clients to go back and look in their cell phone, and they still have the text messages from 2 years ago when they were texting with somebody about this patient, which is sometimes very helpful and sometimes not. It would be better if it's just in the electronic medical record, because as I said, you know, a lawyer is not going to get any of this stuff until suit's been filed. So even if the text messages help you a lot in terms of justifying what your rationale was, or even if that email that you sent the patient sort of suggests that your version of the story is correct and you did educate them, once a lawsuit has been filed, it is sometimes hard for lawyers to walk away. You know, they get invested in a case, they have a relationship with their client, they believe in it, they've spent money on it. You know, it's not cheap to get copies of medical records and have a doctor, you know, at a few $100s an hour review them for 10 hours and file a lawsuit. And sometimes it's not until we get to the point of taking depositions that some of this stuff starts coming out. And even though it's helpful, if at that point the the lawyer's got $10 or $15 or $20,000 invested in the lawsuit, for them to just dismiss the case and walk away is difficult. You know, people have a tendency to throw good money after bad, and so the case may not go away just because you found the smoking gun that helps you. So this stuff needs to be in the part of the record that the lawyer is looking at the beginning, when they decide, you know, this is probably not a case I want to put any money into. That's when they need to have this information. But if you get to the point of a lawsuit, you need to know that people are still going to ask for your cell phone stuff. Patients may have kept voice messages. Patients may have recorded your conversations without you knowing about it. That's not terribly uncommon. So a lot of additional information may come out in the course of the litigation, and you want to make sure that it is not hurtful to you, either the case in terms of explaining the care, or not hurtful to your credibility or professional reputation. So this is an example. I can read this out loud. Can y'all read this in the back on the big screen or not? Yes. Okay. I'll let you read silently. So this was an actual lawsuit. The ER physician was sued, the hospitalist was sued, and the cardiologist was sued, and one of them still had these messages on their cell phone. And so when the lawsuit was filed, the plaintiff's lawyer asked for the production of all of these text messages, and they're not protected by any law. They are discoverable information. We were required to turn these over. And, this makes the case, even if the care was good, this makes the case pretty indefensible. I mean, you're not going to go in front of a jury with this information. So it sort of forces us to settle cases like this. Here's another one. Can y'all read these? Okay. This one goes on for a few slides, so. So, that whole string of text messages was in a real lawsuit. So now we have our own people saying somebody needs to go where they can get good care and we're going to kill a patient. Again, not defensible. Please reserve comments like that for times when you are alone with your family, and please do not put them in text messages, and recognize that you need to have a professional tone in any of your communications, oral or written, with patients or with patients around, because they may be captured for posterity in one form or another. And then the last sort of topic I wanted to talk about briefly, and then I've left a few minutes for questions, is I know that almost everybody in this room, probably everybody in this room, went into this field, at least in part, because you really want to help people and you really want to take care of people and you want to make people feel better and be happy. And that is laudable, and you will have many, many opportunities to do that in your career. There are some patients who you cannot help. Either they cannot be helped, or you are not the person to help them, or what they think is help is not. It is really important to learn how to recognize those patients and tactfully extract yourself from dealing with them or from trying to placate them. It is okay if a patient is asking you to do something for them that will make their lives more convenient or more pleasant that you do not think is medically indicated, to tell them no, to refer them to somebody else, to simply not agree to do what they're asking you to do. I cannot tell you how many cases I have where the physician says, I knew better and I did it anyway, either because I felt sorry for the person or they were very persuasive. So I have a case right now with a patient who needed a cardiac catheterization, had blood thinners that morning. It was not an emergency. The physician said, we really need to wait until the blood thinners clear your system before we do the procedure. It was a Friday. It was in a hospital where they didn't do those procedures on the weekend. So now this patient was going to have to wait till Monday. The patient had already been in the hospital for 3 days, did not want to stay in the hospital over the weekend. Please, 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 can't you please do this? The risks are low. And the doctor went ahead and did it, and the patient bled and had to have a vascular procedure and then had to have a urologic procedure and then died. Now, I'm not saying that physician violated the standard of care, but he knew better than to do it, and he did it anyway, and now the family has sued. So that's one example. I have a case right now where a patient probably needed to be kept in the hospital, pregnant patient, and to be monitored because she had preeclampsia and she had some risks associated with that and was close to term, did not want to stay, was allowed to go home. And the note in the record says, I offered for the patient to stay at the hospital. Okay. So it doesn't say patient was discharged AMA. It doesn't say patient was recommended to stay at the hospital and refused. Why? Because the physician wants to be nice to the patient, doesn't want to criticize the patient in the medical record. So what it says is, I offered for the patient to stay. A couple of days later, that patient had an abruption and a stillbirth. And so there is a lawsuit about it now. And, you know, the patient's explanation of the conversation is, well, she said I could stay, but she made it really clear that I didn't really need to, and I was going to be a burden. And so I just decided I really had to go home because I didn't feel like I was really being encouraged to stay at the hospital. So it's just not documented in a way that is very easy for us to refute the patient's version of that story. So, you know, if you have a hard conversation with a patient, you need to document the hard conversation with a patient and not sugarcoat it. And if someone is asking you to do something that you feel less than 100% good about, you need to say, I don't think that's in your best interest medically, and therefore I can't do it. You need to recommend that they get a second opinion, refer them to a colleague. If you cave into patients like those are the ones that often come back to bite you. So don't hesitate to say no if you really think that that's in the patient's best interest. Patients with unreasonable expectations are another similar category. I hope I haven't bored you to tears, and I'm happy to take questions for as long as you are allowed to stay or have any.
Well, thank you very much. It was very educational, a lot to learn.
Absolutely.
We'll open it up for discussion or challenges or sharing of anything. This is important material, running through it.
Mm-hmm. You know what? That's a good question, and I actually have a good example of this. So don't worry about it, and you should put your own assessment. Don't delete what the trainee has put. Just say, you know, I've reviewed the above. You know, happy for Dr. Smith's input. This is what I think is what's really going on. We actually tried a case for Emory. This was Susan's case with us. We tried an ophthalmology case for Emory almost exactly 2 years ago, where a resident had put a patient come to the ER with eye pain. A resident had put this huge differential, which is what residents are trained to do, right? Put everything down, and it included giant retinal tear, which is not what the patient had. But that may have been the instigator for the litigation, because the patient got it in their head that they had a retinal tear and were frustrated that the retina team wasn't operating later, and that the patient did not have a retinal tear or any other operable condition. But we took that case to trial, and we were a little worried about that, and the jury had no issues with it whatsoever. I mean, we had the resident testified and said, look, I was a dummy, I was young, I didn't know what I was doing, you know. Later, somebody, in fact, on that patient, his attending physician had read the note and had him come to the exam and said, this is what you're seeing. That's not a giant retinal tear. It's cysts. Here's what a giant retinal tear looks like. You know, so it was a teaching moment for that resident. And the jury said, after we talked to the jury afterwards, and they said, of course he was a resident. He's in training. That's what he's there to learn. We never thought the patient had a retinal tear. We completely trusted the attending's assessment. It was not an issue at all. So, you know, put what you think is right. Don't criticize the resident, but don't change anything. And use it as an opportunity to teach. That's what I would say. Yes. Mm-hmm. Yeah. Yeah. I'm not as concerned about, I think you let them leave and give them the medication. And I'm not as concerned about the technicalities of whether they actually sign the AMA form or whether you discharge them, as long as you describe in detail in the discharge note, you know, this is the conversation I had with the patient. I strongly recommended that they stay for IV antibiotics. I explained to them why IV antibiotics were preferable, why it was important that we be able to monitor them while they're here, why all the reasons that I thought that discharging was a bad idea. Patient insists on leaving. I mean, I think you can even just put there in the note against my advice or against my recommendation. Under these circumstances, I am prescribing oral antibiotics because it is the only alternative that's available here.
Let me add on that. If you have that patient and they want to leave and you are friendly with them, you say against the medical advice, you put that in your note, against medical advice. Isn't there insurance out?
There in the patient's insurance?
Yeah.
Oh.
They cannot be paid.
See, this is not my area of expertise. I don't know how so I'm not as familiar with the like reimbursement rules for insurance. I'm only familiar with the medical malpractice insurance on the doctor's side, really. Is that true? I don't know. I haven't, although it seems reasonable, right? If they aren't following their doctor's advice, that they don't. I don't know though. Haven't heard that.
So you weren't sure.
Yeah, I haven't heard that, but not at all my area of expertise. It sounds reasonable, but I don't know. Yeah, it might be a billing question.
Yeah, no, I know it did, and I understanding it, that did have an effect on the payment by the might be wrong. Anybody know? Anybody out there?
I've always heard that rumor.
Check that out. Okay. Other questions, other comments? I guess one other thing that you're seeing today is that in medicine is that we've moved more from a solitary physician seeing a patient to a team of people seeing a patient.
Yeah.
And it looks to me like that brings on the threat of more people. If somebody comes by, say a house officer, and talks to the patient afterwards and gives the wrong information or something. But
yeah.
Are you seeing that effect of that or not?
Yeah, I think it's just more opportunities for the ball to get dropped in terms of communication. You know, there's a lot of delegation and people having to pick up pieces of information from another source. And I just think there's more opportunities for people not to have seen information. Just like I think it's more opportunities because of the volume of the electronic records and how much data is there. It's more chances for something just to get overlooked because, you know, in the old days, you have one note, had everything written on it. It was pretty easy to follow. So there's pros and cons to all of that. I do think the sort of stratification of healthcare among many different team members means that people have to be extra focused on making sure they've communicated well and making sure that they are careful about what they say. Like you said, you know, you say something that's different from what someone else said and make patients confused. So making sure that the team is on the same page before information is imparted to patients, you know? Yeah, that's definitely true. Yep. In Georgia, yes. Yep. 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 Yes, and yes. So Georgia's a one-party consent state, which means as long as one party to the conversation is aware of and consenting to the recording, then it can be recorded. So you could record a patient without the patient knowing. I wouldn't advise it, but you could do it legally. Yeah. And other way around, videotape's the same thing. Yeah. But you can't record, like if you knew a patient was having a conversation with a resident, you couldn't leave a recorder in the room and leave because if neither one of those people knew about it, because neither party to the conversation would be aware and consenting. Oh, good. That would be my recommendation.
Any other comments? Again, many thanks. I think we are better informed. We still got a lot to learn.
All right. Well, you can't, if you learn too much, I'll be out of a job soon. All right.